This is Dr. Julie Huffmeyer with our Open Anesthesia Intraoperative TEE Case of the Month for April 2012. Each month we feature an operative case which teaches or emphasizes an important aspect of basic intraoperative TEE. Our patient this month is a 73-year-old woman who presented with 1 year of progressive fatigue and dyspnea on exertion. She had a mitral valve repair with resection of a fibroelastoma in 2003. At the time of this first mitral valve repair, she was noted to have some systolic anterior motion of the mitral valve. She also has a history of COPD requiring home oxygen use of 2 liters per minute at night. Our patient presents for reduced sternotomy and septal myectomy to treat her hypertrophic cardiomyopathy. Our patient's preoperative transthoracic echocardiogram showed normal left ventricular size with ejection fraction estimated at 60 to 65%. She had asymmetric septal hypertrophy with a peak gradient of 137 millimeters of mercury across the left ventricular outflow tract. Her left atrium was mildly dilated. There was significant systolic anterior motion of the mitral valve with left ventricular outflow tract obstruction. She also had moderate mitral regurgitation and moderate mitral stenosis. She had evidence of pulmonary hypertension with pulmonary artery systolic pressure measured at 53 millimeters of mercury. This is the mid-esophageal 4-chamber view seen preoperatively in the operating room for our patient. The anterior mitral leaflet and septum are labeled. Note the motion of the anterior mitral valve leaflet. It comes down and makes full contact with her thick shelf-like interventricular septum and then bends almost at a 90-degree angle, being pulled out into the left ventricular outflow tract. This is known as the Venturi effect and will be reviewed a little later in the podcast. This is the mid-esophageal 4-chamber view at 0 degrees with color imaging placed across the mitral valve. Turbulence of flow is noted in the left ventricular outflow tract with various hues and speckling of color at the area of the interventricular septum, and there is posteriorly directed mitral regurgitation noted into the left atrium. This is a side-by-side close-up view of the mitral valve with and without color flow. In the left box, the anterior leaflet of the mitral valve is seen again to make contact with the interventricular septum, and on the color flow box on the right, significant turbulence of flow is noted in the left ventricular outflow tract as well as the mitral regurgitation. Hypertrophic cardiomyopathy is the preferred name of this disease as it describes the features of the disease. It is important to understand that obstruction of the left ventricular outflow tract is not a mandatory feature and is dynamic in nature. Historically, this disease has also been known as hypertrophic obstructive cardiomyopathy, or HOCM, and idiopathic hypertrophic subaortic stenosis, or IHSS. There is marked heterogeneity of the clinical features of hypertrophic cardiomyopathy. It can present in infancy through old age, and patients can be asymptomatic with normal longevity, moderately affected with diastolic heart failure, or can present dramatically with sudden cardiac death. It is recognized as the most common genetic cardiovascular disease transmitted in an autosomal dominant fashion. The estimated phenotypic expression of hypertrophic cardiomyopathy in the adult population is 1 in 500 patients. Due to the spectrum of disease progression and presentation, there are many patients with unrecognized hypertrophic cardiomyopathy. The features of hypertrophic cardiomyopathy distinguish it from other myocardial conditions and include primarily a myocardial tissue abnormality with sarcomeric disarray and asymmetric left ventricular hypertrophy. The hypertrophied muscle cells consist of bizarre shapes with multiple intercellular connections in a chaotic pattern. There is increased connective tissue deposition, which contributes to increased chamber stiffness and impaired ventricular relaxation, leading to diastolic heart failure. Impaired diastolic relaxation causes increased left atrial pressure and the development of pulmonary congestion and pulmonary hypertension over time. This diastolic dysfunction, in addition to the unstable electrophysiology associated with hypertrophic cardiomyopathy, predisposes to complex arrhythmias and sudden cardiac death. Left ventricular systolic function is usually normal until late in the disease process. Myocardial hypertrophy in hypertrophic cardiomyopathy is the most extensive of all cardiac diseases. The size of the heart may be increased as much as 100%. Chamber radius is not responsible for the enlargement, but wall thickness is the contributing factor to increased muscle mass. The myocardial hypertrophy is not related to increased systemic vascular resistance as in cases of hypertension. It is a non-uniform, asymmetric hypertrophy that typically affects the basal anterior ventricular septum and the free wall. Hypertrophy occurs less commonly at the apex of the heart, the lateral wall, or in a concentric fashion, and the posterior free wall tends to be unaffected. Using transthoracic and transesophageal echocardiography to evaluate hypertrophic cardiomyopathy is especially helpful as it allows the clinician to directly visualize the morphology of the disease and location of the hypertrophy. Doppler and color flow imaging are useful to evaluate for left ventricular outflow tract obstruction and mitral regurgitation. When continuous wave Doppler is placed across the left ventricular outflow tract, a dagger-shaped appearance is noted. This is done from the apical position of the transducer for transthoracic echocardiography or from the deep transgastric view for transesophageal echocardiography. Mitral regurgitation accompanies the left ventricular outflow tract obstruction. There is narrowing of the left ventricular outflow tract due to the septal hypertrophy, and this causes an increase in blood flow velocity. This increase in velocity draws the anterior mitral leaflet into the left ventricular outflow tract. This is known as the Venturi effect. When the anterior mitral leaflet causes obstruction to blood flow, there is posterolaterally directed mitral regurgitation. The left ventricular outflow tract obstruction associated with hypertrophic cardiomyopathy is considered to be a dynamic process. There are more complexities to systolic anterior motion of the mitral valve than the Venturi effect alone, and we are not able to thoroughly review these during this podcast. Here is the same mid-esophageal four-chamber view shown earlier in the podcast, the spotlight here demonstrating the way the anterior mitral leaflet comes down and contacts the interventricular septum, and then is pulled or swept out into the left ventricular outflow tract. This anterior mitral leaflet obstructs the forward flow of blood into the aorta and out to the systemic circulation. This is the continuous wave Doppler profile of the velocity of blood flow at our patient's left ventricular outflow tract. Note the dagger-shaped appearance of flow as compared to the usual rounded envelope that is normally seen in patients without turbulence at the left ventricular outflow tract. The peak velocity here is 3.5 to 4 meters per second. This corresponds to a peak gradient of 49 to 64 millimeters of mercury. Remember that on our patient's preoperative transthoracic echocardiogram, her peak gradient at the left ventricular outflow tract was estimated at 137 millimeters of mercury. This intraoperative gradient is elevated, but not nearly as high as her preoperative gradient. The left ventricular outflow tract obstruction in hypertrophic cardiomyopathy is dynamic in nature, affected by preload and ventricular filling, diastolic relaxation of the ventricle, and systemic vascular resistance. This is a close-up view again of the mitral valve and septal relationship. It is important to note the contact of the anterior leaflet of the mitral valve in this case and bending or sweeping of the leaflet into the left ventricular outflow tract. Intraoperative TEE is vital for patients undergoing surgical myectomy for hypertrophic cardiomyopathy. To help guide surgical planning, TEE can localize the hypertrophy in relation to the position of the aortic annulus and measure the thickness of the ventricular septum. Inspection of the mitral valve is critical prior to surgery in order to identify structural abnormalities of the mitral valve annulus, leaflets, and chordae. It is especially important to look for central or anteriorly directed mitral regurgitation, as this indicates another problem with the mitral valve unrelated to systolic anterior motion or left ventricular outflow tract obstruction. After the myectomy, TEE is used to assess for residual mitral regurgitation, systolic anterior motion, and left ventricular outflow tract obstruction. Doppler imaging should demonstrate reduction of the gradient across the left ventricular outflow tract. The ventricular septum must be inspected for a possible iatrogenic ventricular septal defect after muscle resection. On color flow imaging, it is common to see some shunting of blood near the septum due to transection of perforating coronary vessels at the site of the myectomy. This usually appears as flow into the left ventricle from these vessels during diastole. If a true iatrogenic ventricular septal defect were found, the blood would be shunting from the left ventricle into the right ventricle during systole. For our patient, a significant portion of the hypertrophied septum was resected, and the aortic valve was normal on inspection. Separation from cardiopulmonary bypass was uneventful, although she required some inotropic and vasoconstrictor support due to her pre-existing right ventricular dysfunction and pulmonary hypertension. Here is a post-bypass mid-esophageal four-chamber view. The septum appears less thickened, and the anterior mitral leaflet does not get swept out into the left ventricular outflow tract. This is that same four-chamber view with color flow placed across the mitral valve. Her mitral regurgitation appears to be significantly reduced, thus indicating that at this time in the post-bypass period, her left ventricular outflow tract obstruction has been relieved. In the deep transgastric view of the aortic valve and left ventricular outflow tract, the post-myectomy gradient was decreased to 20 millimeters of mercury. This is a significantly reduced gradient from her preoperative echocardiogram. This is a mid-esophageal long-axis view at 120 degrees with color flow placed across the mitral valve, aortic valve, and left ventricular outflow tract. Our patient continued to have some intermittent systolic anterior motion of the mitral valve with posteriorly directed mitral regurgitation, and this improved throughout the immediate post-bypass period with volume administration and reduction in the level of inotropic support. Hypertrophic cardiomyopathy is a disease of the myocardium causing hypertrophy of the left ventricle and impaired diastolic heart function. There is significant variation in disease presentation, severity, and progression, with some patients remaining asymptomatic, others being mildly affected, and a small number of patients with severe disease that leads to sudden ventricular arrhythmias and cardiac death. The classic presentation includes the patient with left ventricular outflow tract obstruction due to systolic anterior motion of the mitral valve and associated mitral regurgitation. Myectomy is a surgical treatment for such patients, and TEE is an important tool in guiding the surgical and perioperative management for patients with hypertrophic cardiomyopathy.